Hello, everyone. We'll get started. We know that more will join. We have about 40 registered for today, so we may see some more faces turn up. My name is Kelly Kay, and I'm the Executive Director of Provincial Geriatrics Leadership Ontario, and we're really pleased to bring you this presentation today, prepared by our colleagues, Dr. Kathleen Bingham and Dr. Kevin Young, who I'll introduce in a moment. This presentation has come about because of work we did collaboratively with Ontario Health to develop the recent Delirium standard. So as part of our commitment to support the dissemination of the standard, our two colleagues have joined today to just help convey information about how we can put this into practice. And they've titled the presentation, Delirium Awareness, Untapped Potential for Patient Care and System Transformation. So before we dive in, I'm just going to do a land acknowledgement. I'm also just aware that we have a little bit of background noise, so I'll just ask you to mute if you're not wanting to speak or ask a question. And I'll also be watching the chat for questions so that we can have those at the end of the presentation. Do take a moment and introduce yourselves in the chat. It's always good to know who else is interested in this topic. Feel free to pop your introduction into the chat. So before we begin, I would like to acknowledge the land that we're gathering on today and that I sit on right now is the traditional territory of the Anishinaabe, the Mississaugas of the New Credit First Nation, the Haudenosaunee, and the Huron-Wendat. We acknowledge these people because they have the longest and wisest relationships with this land, a relationship that extends back hundreds and thousands of years. We also acknowledge that today this meeting place is still home to many Indigenous people from across Turtle Island. We are committed to acknowledging the land before meetings because it's important to remind ourselves that we are working on behalf of all residents of Ontario, including Indigenous people who have been and continue to be negatively impacted by Canada's colonial history. I recognize that many of you are attending virtually today and you are working on parcels of land that do not apply to this particular land acknowledgement. I do invite you to take some time after the meeting to learn about the colonial history and the treaty history of the land you live and work on, and to think about how it's connected to the important work that you do. So with that, I'd like to introduce our two presenters today and then turn things right over to them. So I'm very pleased to present Dr. Kathleen Bingham, Katie Bingham. She completed her medical training at Western University in 2010 and her psychiatry residency at the University of Toronto in 2015. She then completed a PhD in medical science through the University of Toronto's Institute of Medical Science in 2019. She's a geriatric psychiatrist and clinician investigator based at the University Health Network in Toronto and affiliated with the North Simcoe Muskoka Specialized Geriatric Services. So very pleased to welcome Katie. And Dr. Kevin Young, he completed his PhD, there's a common theme here, at the University of Toronto in laboratory medicine and pathobiology. He subsequently completed his medical degree at the University of Toronto and a residency in internal medicine and fellowship in geriatric medicine. He currently works as the medical director of integrated care at Waypoint Center for Mental Health Care and is the physician lead for specialized geriatric services in North Simcoe, Muskoka. And we're pleased to have him as the co-medical director of Provincial Geriatrics Leadership Ontario. Dr. Young's committed to providing quality care to patients and helping to create a healthcare system that functions well to address the needs of vulnerable people in the community and in institutions. And it's my absolute pleasure to have you both here. And without further ado, I'm going to turn things over to Kevin and Katie.
Thanks, Kelly, for that very nice introduction. And thanks, everybody, for coming today. We're very excited to be presenting on this topic. It's something that is our bread and butter that we see every day, but despite that, very under-recognized and a huge opportunity for the system to both improve, provide better care, as well as to save money. And so something that we should be paying a lot of attention to. What we hope to be able to achieve today is just that you'll be able to recognize delirium as sort of a medical emergency and appreciate its clinical implications, to effectively screen, diagnose, and manage delirium in individual patients, and also to transform care by utilizing the new delirium standard to implement institutional delirium awareness, screening, and monitoring. And we're very pleased that delirium has been recognized, and that there has been a quality standard implemented, and we're very pleased that we were able to be partners in the production of that. So here's a couple of quotes from the part of the team that helped to make the delirium standard, and I think it just helps to really illustrate sort of what delirium feels like from the patient and family's perspective. And sometimes we forget, because we see it every day, what it really feels like to somebody who doesn't understand it or anticipate it or know what's happening. And so I'll just read a couple of quotes here. My husband was discharged home after a week in the ICU and soon became very disoriented and agitated with some periods of lucidity. It was extremely frightening for both of us, and I wasn't sure how to help him. We eventually found out that he was very dehydrated, which led to symptoms of delirium. When he was discharged, he was still quite frail, and we didn't have any information or strategies for delirium prevention, which I'm sure would have helped both of us. With this experience, I can see how the delirium quality standard would have been helpful. All of the statements are interrelated and all important to guide patient care. My biggest hope is that the quality standard is applied in everyday practice to support patients, families, and caregivers in whichever setting or region across Ontario they are from. Education and preparedness are extremely valuable for patients and caregivers. So I think that's very well said. And a second quote, as a nurse practitioner in geriatrics, I've seen many patients who developed delirium in the emergency department and on the wards. It often goes undetected and can lead to significant challenges and harms for patients and their families, as well as for healthcare providers. The quality standard on delirium is important because it raises the state of delirium as a clinical entity and gives providers a standardized, logical approach with key metrics and indicators to track. Reinforcing the importance of this condition will also help to educate and empower families and caregivers. And the key metrics and indicators are an important part of the standard. It's not part of what we're presenting today, but if that's of interest to you and you're coming from an institution that wants to be able to do that part of the standard, then I do encourage you to go to the Ontario Health website, and all of the tools and metrics are there, as well as the complete delirium standard. So I'd first of all like to just start by introducing, so when we're talking about delirium, what are we talking about? There's many definitions that are out there. One of the most widely used definitions is found in the DSM-5, which is very similar to the DSM-4 criteria. So the first criteria is a disturbance in attention and awareness. It develops over a short period of time, which is generally thought to be hours to days, represents a change from baseline, which means that we need to know what the baseline is, and tends to fluctuate in severity during the course of the day. So three very, very important things in item B. It's an additional disturbance in cognition, whether it be memory, disorientation, language, visual, spatial ability, or perception is also present. It's not better explained by a pre-existing neurocognitive disorder. In other words, it's not a type of dementia, it's different from the normal baseline. And lastly, evidence that symptoms are a direct physiological consequence of another medical condition, substance, or medication side effect. So we're going to introduce a bit of a case just to sort of, think through how we would operationalize this. Obviously, the ways that delirium presents can be very different from one individual to the next, and sometimes patients present with what we call hypoactive delirium, where they'll have a decreased level of consciousness and will often go sort of unrecognized because those patients are often easy to care for in settings. And in other cases, patients will present with hyperactive delirium, where they're sort of very ramped up or very agitated for whatever reasons, and those patients often are recognized earlier, but both are exactly the same, and both are delirium, and both need to be treated with the utmost care to sort of understand what's going on. So this particular case is one from many years ago that I saw, an 87-year-old woman who I was asked to see for medication review. She was from long-term care. She was post-operative day 4 for after a hip fracture, and she'd had a dynamic hip screw placed. When I reviewed the chart, then what it said in the chart was that there's baseline dementia, patient was nonverbal, total care in quotation marks, and that was the only past medical history that I could find anywhere on the chart. Her medications are listed here. Many of them were held: aspirin because of the surgery, metoprolol, metformin, which would also been held, She was on Seroquel, which was increased in hospital because of some agitation. She was on indomethacin just for everyday pain, as well as misoprostol in order to prevent bleeding. And she had been started on hydromorphone in hospital, which had been given sort of on a fairly regular basis at reasonably high doses. When I saw her, she had sort of a waxy appearance. She was drowsy, but was arousable, would answer simple yes or no questions with repeated prompting, would not maintain eye contact, was sort of looking all over the room in various, and seemed to be sort of focusing on various things around the room. There was no focal neurologic signs that I could see, although I couldn't perform a full neurologic assessment, and otherwise the examination was unremarkable. And so obviously, from what I've given you so far, there's enough there that we should already be suspecting that maybe this patient is delirious. She's had a hip fracture. She's on a whole bunch of different medications, which some of which have been stopped and some of which haven't been stopped. And clearly there's, some changes to level of consciousness here. There's a patient who's, not being attentive, but we don't really know for sure what her baseline is, and there's still more information that we need to get in order to make a diagnosis. So the question is, how do we make a diagnosis? So we'll come back to that in just a second. Just as a reminder, now that we're thinking about that case, so delirium is actually the third most common harmful event experienced by people admitted to hospitals in Canada. And the reason why we say it's harmful is because it can have very dire effects to patients that have delirium. It definitely leads to increased mortality across sort of all settings, not just hospital. It leads to increased hospital stay and increased placement in long-term care after hospitalization. And so people's lives can be irreversibly changed after they have delirium. And so it's very important to try to prevent it where possible and to try to identify it early in order that we can treat it and try to get people better and make the families sort of aware of what's happening. Delirium is very common in older people in hospital settings, and the rates vary widely sort of from one estimate to the other, probably because it can be very difficult to diagnose and it's often sort of underdiagnosed or underappreciated, but certainly it's at least a third to 2/3 of patients, which is quite significant when you think about how many patients we see. And the prevalence in the community is lower, but that 1% to 2% require emergency care, and so it's very, very important to recognize who they are and to make sure that we understand what the underlying cause is and have given them the appropriate treatment. Some of the settings that have the highest incident rates are palliative care, which is probably at least half of patients from many estimates, which if you stop and think about it, it makes sense, but we often don't think of palliative patients as being delirious, but in fact, we give them medications on a regular basis to treat that delirium. Intensive care is also a setting where it's quite high. Post-surgical care, long-term care, or post-acute care, then older people who present to the emergency department. And as I've said over and over again, it's often unrecognized, misdiagnosed as another disorder, in particular misattributed to dementia. It's probably only recognized in about a third of cases, which is really, really important because in 30 to 40% of cases, it can be prevented if strategies are used in order to try to sort of recognize the risks and mitigate those risks. And Katie's going to talk about that later on in the talk. But if you think about 30 to 40% of cases that could be prevented, and you think of how long people stay in hospital and how much they become deconditioned and how much more care they need or increased care settings they need because of it, then you can very quickly appreciate both how much better it would be for care if we were able to prevent all of those cases, as well as how much money that we could save the system. So the first quality statement in the delirium quality standard is around identification of risk factors for delirium. So the recommendation is that on initial contact with the healthcare system, people are assessed for risk factors for delirium, especially when they present to hospital or long-term care. Any risk factors are documented in their record and at transitions of care, and are communicated to the patient, their family, the caregivers, and the healthcare team in order that that we can sort of be aware of it and use strategies to mitigate it. So I'm now going to talk a little bit about screening and diagnosis. So who's at risk for delirium? Well, here's some of the sort of top risk factors that we sort of think about. So anybody that's age 65 or older, which is obviously a huge portion of our healthcare system. If one has cognitive impairment or dementia, that puts them at further risk. Hip fractures is a huge risk factor. Any severe illness or clinical condition that's deteriorating or is at risk of deteriorating puts people at risk. Having had previous delirium is a risk factor. That's always the bonus point on medical school exams. So we always have to add that one to the list. And having alcohol or substance use is definitely a risk factor because withdrawal from substances is a huge cause of delirium. But those aren't the only risk factors. Other neurologic disorders like strokes and Parkinson's disease, having multimorbidity, having sensory impairment, so that we're not getting a full picture of what's happening around us, are all things that can sort of predispose us to having delirium. And then there's several things that can kind of perpetuate it. We've already talked about substances, but having infections, metabolic disturbances, various traumas, dehydration, malnutrition, et cetera, can all be things that can perpetuate or precipitate delirium. And so very, very important when you're dealing with delirium to be thinking about the whole picture and thinking about all the things that could be causing it. So the quality statement number 3, we're going to come back to number 2, but quality statement number 3 is early screening for delirium. So people presenting to hospital with any risk factors for delirium or have an acute change in behavior or cognitive function are screened for delirium in a timely manner by a healthcare professional who is trained using standardized validated tools. The person and their family caregivers are asked about acute changes in the person's behavior or cognitive function, and often not always the person, but definitely the family and caregivers are often the first ones to kind of recognize that change, since they know the individual so much better. And involving the family and those that know the patient is absolutely key, because as we mentioned at the very beginning, it's really important to know what the baseline is and that there's been a change from the baseline. And so involving the family in that is absolutely essential. The screening tool that we use most often is the confusion assessment method. We use it because it's also very useful for diagnosing delirium. It overlaps very closely with the definition that I gave you earlier, and many of us sort of use it as sort of the gold standard. There are other ways of screening for delirium, and obviously just seeing patients with delirium and having pattern recognition is important, but we like to use this tool. It's evidence-based, involves both direct observation as well as a brief cognitive assessment. The psychometric evidence is very good. There is a modified version that can be used in the ICU called the CAM ICU, which we won't present here, but if you work in the ICU, very, very important to know that tool, and specifically designed and very sensitive and specific in that environment. It's less studied specifically in patients with dementia, but obviously dementia is a huge risk factor for delirium, and so we use it all the time in those patients. So this is what the CAM looks like. There's 4 criteria. The first is acute onset and fluctuating course. So there's actually 2 things that you need to look for there. So you assess this from having collateral sources from a knowledgeable informant. Plus, you can watch patients over time, and so you might get to know what their baseline is, and then you might detect a change from their baseline, and then be able to recognize that they're delirious. The second criteria is inattention. So sometimes we can recognize this clinically when patients can't focus and are looking around the room, as was the case in the case that I presented. But if not, we can use bedside tests like asking the patient to tell us the months of the year backwards, or do digit spans or serial subtractions, those types of tests of attention. So you need to have both items 1 and 2, and then you have to have one of either item 3 or item 4, although sometimes they're both present, which is absolutely fine, but you need to have at least one of them present. So item 3 is disorganized thinking. So you discover this through a mental status examination. So this is a patient that's got a tangential thought process. They might be rambling or have incoherent conversation, and you might recognize that right away as being disorganized thinking. Or they may have an altered level of consciousness. And again, we recognize that through the mental status examination. But like I mentioned earlier, patients might be alert, they might be hypervigilant, they might be drowsy, they might be difficult to arouse. They may in fact be in a complete coma, And I've been called many, many times for patients that are in a coma and we can't wake them up. And in fact, it's a sign of delirium. And if we wait an hour or two, often then they'll have a change to that level of consciousness. And this altered level of consciousness can also fluctuate over time. So it's important to watch for that as well. Just a little side note for those that are keeping notes. So there is a bit of a differential diagnosis for delirium. There are some other conditions that can cause, in particular, the fluctuations. And so important to be extra vigilant in patients that, where there may be some fluctuations for other reasons. So for example, dementia that would sundown sort of at night when people get more fatigued, and then their mental status might change as a result of that. But often you'll get that from history, and you'll discover that that's been longstanding. People have dementia with Lewy bodies, can have fluctuations as well, and that's one of the diagnostic criteria of that particular disorder. So again, important to have a history of that. Focal neurologic deficits, like, and patients that have Wernicke's or bifrontal lesions, can have fluctuations and can present sort of very differently, or non-convulsive status can also present with sort of changes that vary over time. And so just important to sort of keep your wits about you when you're thinking about that. So in Ontario, we have some statistics around delirium. So 92% of hospitals in 2014 reported using delirium screening and detection processes, which was a dramatic increase from the previous time that data was collected, which was in 2011. So this is promising because it shows us that people are becoming more aware of delirium. Having said that, my experience is probably similar to many others in that, when we're screening for delirium, often that screening isn't being done as well or as thoroughly as we could. And so I would still argue that there's a lot of work to be done. There's also a 47% increase in the number of inpatient admissions with documented delirium between 2014 and 2019. In 2019, 2020, there were 8% of hospital admissions among older adults had a documented diagnosis of delirium. So if you compare that to the numbers that I told you before, the fact that it's increasing tells us that we're getting better at recognizing it. But if we're accepting that, a third to 2/3 of patients over 65 probably have delirium at some point during their stay, then we're probably still vastly underdiagnosing delirium, and still there's a lot of work to be done. But great to see the trend heading in the right direction. It means as a healthcare system, we're becoming more in tune with this important problem. And again, in 2019, 2020, about half of hospital admissions with delirium it presented prior to admission, where about 27% presented after admission. And so again, important to think about, that delirium might already be there when the patient comes, or it might come during the hospital stay. And so you have to be vigilant in watching for that, and being able to, try to prevent it and treat it as it comes. So I'm now going to turn over to Dr. Bingham to talk about the management of delirium, and we're just going to switch slides for just a second here. So just bear with us.
Okay, great. So can everyone see my slides here? Oh no.
Not yet.
Not yet. Okay, I think it's just being a little bit slow and switching over. Okay, I think you can see it now, eh?
Yes, but we're seeing the not in slide presentation view. So
yes, here we go. Sorry, I had gotten this organized fully, and of course, when it's time to do it, it's slow. Okay, there we go.
There we go. Perfect. Yep.
Okay, great. So great. So we are going to try to leave about 15 minutes at the end for questions and discussion. So I'll be kind of keeping my eye on time. So as Dr. Young mentioned, I'll be going over mostly management of delirium. So obviously, once we've already identified a patient has delirium, what are the next steps? So this brings us to quality statement number 2. And that is that people at risk for delirium receive interventions to actually prevent delirium in the first place. And these should be tailored to their individual needs and to the care setting. Okay, so Kevin's already talked about some of the statistics from this hospital strategy, or it's the seniors friendly hospital strategy that was done through the RGP and the LINS. And so between 2011 and 2014, hospitals that did report delirium prevention and management procedures increased from 62% to 88%. So that's certainly promising as well. So looking towards the actual evidence that exists for delirium prevention, I've summarized here sort of larger bodies of evidence from systematic reviews and meta-analyses. So really the best evidence is for non-pharmacological delirium prevention. So using multi-component behavioral environmental approaches. And there's evidence for these interventions in both surgical and medical patient populations. And again, as you can see by the relative risk reduction, 0.71 and 0.65, it goes together with what Kevin had already mentioned about how these interventions do have a good effect. So, right off the bat, that is the best evidence is prevention using non-pharmacological methods. There is very little to no evidence for using actually medications to prevent delirium, with the possible exception of the alpha agonist I call it Precedex, dexmedetomidine in the ICU setting. So it's Precedex versus benzos, Precedex versus placebos. There is some evidence that it might actually reduce delirium incidence. But other than that, in terms of other medications, antipsychotics and second generation antipsychotics and Haldol as well in multiple different settings, there really is no difference, at least based on high quality evidence. So one meta-analysis looked at Haldol versus placebo. There was no difference between the two in terms of outcome of delirium, in terms of preventing delirium. And there was maybe a little bit of evidence in a surgical population for a variety of second generation antipsychotics versus placebos, but this was very low quality evidence. So we can't make anything of that finding. There have been a number of other medications studied for delirium prevention as well, including gabapentinoids, analgesics, cholinesterase inhibitors, a variety of anesthetic agents, and melatonin. But those also did not find any benefit above placebo. A small study did find possibly a little bit of benefit for Ramelteon, which is related to melatonin, but this again was low quality evidence. So on the whole, really, to summarize that evidence base, there is no role for pharmacological management to prevent delirium based on current evidence outside of possibly like the highly specialized ICU setting. But fortunately, multi-component non-pharmacological interventions do have good evidence for delirium prevention in hospitalized patients. So multi-component interventions can refer to a number of different things, but typically they include interdisciplinary care that involves social visits, early mobilization, non-pharmacological sleep hygiene protocols, use of hearing and vision aids, staff education, and then involvement of the geriatric team. A common example that people may have heard of is the Hospital Elder Life Program, which was developed by a team in the United States, but is used internationally by some hospitals as a delirium prevention strategy. Okay, so that brings us to quality statement number 4, which education is part of the multi-component intervention. And this statement says that people who are at risk for delirium or who have delirium, as well as their caregivers, are offered education about delirium. And I find that this is one of the most really rewarding parts of my practice is letting people know that what they or their caregiver, or letting the patient or their caregiver know that what the patient is suffering from is something that actually is, typically mostly reversible, and doesn't mean that they've suddenly developed dementia. I mean, often they do have some degree of cognitive impairment, but certainly the delirium can improve we know that people don't always get quite back to baseline, which is why we want to prevent delirium in the first place, but it's important to offer that education and reassurance, and it makes a big difference clinically. Okay, so what do we do when delirium does develop in terms of next steps? So of course, the first step is to identify and treat the underlying cause. That really is, in terms of treatment, that is, really the absolute necessary step and the thing that makes the biggest difference to actually treat the delirium. Don't forget, though, that there's often not just one underlying cause, but multiple different conditions and prescribing cascades that could potentially be contributing. So I've just provided an example here of such a cascade. So the example, and this is separate from the case we discussed before, an 83-year-old woman from home with an unwitnessed fall. She was found to be mildly confused compared to baseline. So this does represent delirium. A workup revealed a UTI, which was then treated with Cipro. So that was a good first step. But then the patient developed GI upset and was prescribed Grapple. Unfortunately, then she developed worse agitation, especially at night, and was prescribed lorazepam. This led then to more severe agitation. So the lorazepam may have increased confusion and led to the use of restraints, insertion of a catheter. So you can see now that there are multiple potential contributors to delirium beyond the UTI that was identified in the first place. So can't forget about looking for other causes, especially if the delirium isn't improving. Okay, so quality statement number 5 says that based on the results of a comprehensive assessment, people with delirium should have a multi-component interprofessional management plan to address the causes and manage the symptoms of delirium. So what are some of the common underlying causes that contribute to delirium? So there are really almost anything can cause delirium in vulnerable people, but some common ones include, of course, fluid and electrolyte disturbances, infections, not forgetting about skin and soft tissue in addition to the usual culprits, drug toxicity. So even with normal levels, older adults are more sensitive to the effects of the negative effects of a lot of medications. Metabolic and endocrine disorders, low perfusion states, withdrawal from alcohol and sedatives, so not only intoxication, but also withdrawal, and then urinary retention, constipation, I would add, sometimes contributes. So the diagnostic tests that we might consider then to look for some of these factors. So for most people, we would do basic investigations, CBC, electrolytes, creatinine, extended lights, urine, urinalysis, and CNS. In some cases, depending on the clinical situation, consider other more detailed investigations, CK, troponins, EKG, thyroid, vitamin B12, liver tests, drug levels, tox screen, blood gases, and then imaging, potentially chest X-ray, neuroimaging, EEG. So this isn't necessarily fully comprehensive, but these are some of the most common things that one would consider. Okay, so going back to the case that Kevin presented earlier. So this lady's investigations were unremarkable with the exception of, a major drop in hemoglobin from post-op day 1 to the day of the assessment. So going from 82 immediately post-op from a baseline of 98 all the way down to 60. So, one could see how that could be contributing to delirium. Okay. So returning to the evidence, again, I summarized here the evidence from systematic reviews with meta-analyses. This is where the evidence is not as good when we start to look at treatment of delirium as opposed to prevention. So even for multi-component non-pharmacological interventions, the evidence has been mixed and on the whole hasn't really shown a lot of benefit compared to usual care. Again, this is for treatment, not prevention. So for once patients have already developed delirium. Doesn't mean that it is not effective. This is a hard thing to study. So it's difficult to study non-pharmacological interventions. For medications, we commonly use medications for delirium, and at least in psychiatry, it used to be thought that medications may have a role in actually treating the delirium by reducing the excitotoxicity, for instance, that contributes to delirium. That hasn't borne out in higher quality clinical trials. So we've looked at antipsychotics compared to either non-antipsychotics or placebo medications. Generally speaking, there was no reduction in delirium severity, no increased resolution of symptoms compared to, in the active treatment arm or compared to the control. A large meta-analysis, well, not that large, but a meta-analysis has looked at Haldol plus lorazepam or Haldol plus placebo to look at, and this was in the palliative setting where benzos are used a little bit more often. No evidence there. Precedex compared to benzos, Haldol or placebo, there was maybe some evidence for Precedex. So this is another case where it may have some signal for efficacy, but this was the quality of that study was not that high, or sorry, of that meta-analysis, the studies were not that high quality. So other medications that have been investigated in RCTs with negative or null findings were second generation antipsychotics compared to Haldol, morphine compared to Haldol, risperidone or Haldol plus supportive care, and midazolam versus supportive care and midazolam alone. And that was in a palliative group of patients, I believe. And no, delirium was actually worse in the group of patients who received antipsychotics. So on the whole, there is no good evidence for medications to treat delirium once it's developed, beyond, of course, treating the underlying cause. So no evidence for, antipsychotics or for other medications to treat delirium. So with that in mind, quality of statement 6 says that only people who are in severe distress from symptoms of delirium or are at immediate risk of harm to themselves or others are considered for antipsychotic medication use. These medications are always to be used in combination with first-line management strategies. If antipsychotic medication is started, it is reviewed daily and discontinued as soon as the clinical situation allows. So, as a psychiatrist, I do use antipsychotics in patients with delirium, but I look at it and sort of provide education to families and staff that it's really like using, Tylenol or something in a patient with a severe infection. So it treats the symptoms. And the additional case in delirium is it may prevent other issues like injuries from, the severe agitation, but it doesn't actually treat the delirium itself. And there's no evidence at this point that it brings about, a quicker resolution to delirium. Okay. So with that in mind, the evidence summary here is that, again, I've already said this, but no evidence for efficacy of really either non-pharmacological or pharmacological treatments for treatment. That being said, the quality of this body of literature is not as good, I would say, as for the prevention studies. And there are some methodological limitations in these treatment studies. So first of all, delirium can be hard to diagnose, especially in patients who have dementia. So studies probably include a mix of people who have true delirium versus who have a mix of dementia and delirium. There's also some uncertainty about what we're measuring. So most studies will measure delirium, like length of delirium or severity of symptoms of delirium. We're not necessarily measuring severity of agitation alone, for instance, which is typically what we'd be targeting with antipsychotics. And there's not necessarily been a lot of studies that look at like quality of life or that sort of thing, although they do look at, very important indices like death. But other than that, the measurements may not be ideal. So that is the evidence for treatment. So the question then is, what do we actually do? Because delirium can be a very difficult clinical problem. And really, again, the best evidence is for prevention. So first, recognizing patients who are at risk for delirium on admission, and then initiating these evidence-based multi-component prevention strategies for high-risk patients, which are a lot of admitted patients. Delirium screening by trained staff using evidence-based tools like the CAM, and then practical things like avoiding deliriogenic medications, and especially in high-risk patients, so benzos, Z drugs, opioids, Gravol, Benadryl, that sort of thing. When delirium does develop, so it's certainly still reasonable to start with low-risk behavioral and environmental approaches. So this would be, again, part of those multi-component prevention interventions, can be used for management too. Reassess for other potential causes. So just because a UTI is being treated doesn't mean there might not be something else going on. And then consider antipsychotics only for patients with distressing and functionally impairing agitation, using lower doses and for a limited time, reviewing the need for the medications throughout the admission, and ideally stopping on discharge. And then considering geriatrics referral for more difficult cases. Okay, so going back to the case that Kevin's had mentioned earlier. So in this case, there was the drop in hemoglobin, so a question of a GI bleed and anemia contributing to the delirium, in addition to the, the post-operative factors. So the management was IV Pentaloc, transfusion, stopping NSAIDs, using Tylenol instead for pain to try to reduce the use of opioids, which could also be contributing to delirium. Also reducing quetiapine, which could theoretically also be contributing to delirium and may just not be needed at that dose. And then to manage the diabetes, again, to reduce another potential contributor to delirium, insulin was started to bridge until metformin could be reinitiated. And I don't have maybe Kevin can comment after on the outcome, but I'm guessing that this was helpful. It sounds like a good management plan. So that brings us to quality statement number 7, which is when the patient has been sort of treated, delirium hopefully resolved, it's getting time for discharge. So quality statement 7 suggests that people with current or resolved delirium, as well as family and caregivers, are given information related to delirium and its management. This information is communicated to those involved in the person's circle of care and documented in the health record at transitions in care. So, transition to another hospital or floor, and as well as discharge to community and community care team. Okay, so delirium is as we can see from statistics that we showed earlier, delirium is an increasing area of interest, and the importance is increasingly being recognized. We do have Health Quality Ontario's, the delirium quality standards that we're talking about today. And in the research world, there's also the Network for Investigation of Delirium Unifying Scientists, which is looking to develop a core outcome set of measures for delirium research that will help with the problem of heterogeneity and measurement issues. And there's also the International Federation of Delirium Societies, which has proposed a diagnostic framework to help diagnose delirium in the setting of dementia specifically, which can be a tricky diagnosis. Okay, and then from a more local perspective, if people are interested in learning more about delirium implementation strategies, the RGP is hosting web education seminars, October 28th, November 25th, and December 16th. And that is the registration information. And I'll finish there. I'll let Kelly add if there was anything else that I didn't cover in terms of the implementation coaching series. And I think we have time for discussion as well.
Thank you both very much for that comprehensive overview. I do note that there's a couple of colleagues from the Regional Geriatric Program of Toronto, so we'll take some questions first. We have a couple in the chat that I'll point out, and then maybe we'll hear from our colleagues at the RGP of Toronto about the coaching series for those who want to continue on or spread the word to other colleagues. So let's go first to Jim's question. Jim asks, is there a system, and he listed one called Care4 as an example, between different hospitals that would identify a patient at the time of arrival in any hospital of a current or past delirium incident? I think that's a nice wish, but I just wonder, what does that look like if someone's coming into your organization? Are you getting word about that? So
I haven't heard of any comprehensive systems. I think traditionally people are just using a review of the medical record in order to sort of identify that, which, as we know, is hit and miss and takes time, and especially in a busy emerge, that may not be done comprehensively. Having said that, this is why the standards point out that that education and awareness of the patient and family is really important, because often that will be the source where people will find out when somebody's in emerge. Oh, last time they were in hospital they were delirious, and then there could be some awareness there. And certainly I think there would be room for having care plans that would follow patients between different institutions, that would include things like previous history of delirium, and what things were necessary in order to treat it and in order to prevent it. And so I would encourage, as the OHTs come online and we're thinking about care plans and we're thinking about different settings, that that delirium sort of be part of that work. But I'm not aware of any comprehensive sort of ways of communicating it right now.
So Jim, I note that you're on a board, so that might be something that you can also use your powers for, to advocate for this kind of crosswalk between organizations, so this information follows patients. We'll go to the next question. David asks, do you see delirium misdiagnosed when it is, I'm seeing the term BPSD, I think we're talking about responsive behaviors, and therefore represented higher incidence? And maybe I'll turn that one over to Katie to start.
So do we see delirium misdiagnosed as BPSD? Yes, definitely, especially in patients who have both underlying dementia with responsive behaviors and an intercurrent medical issue leading to delirium. And so I would say yes, it's underdiagnosed in those patients, and that is part of what some of the emerging research is looking at, how to actually diagnose delirium in the setting of dementia when people do have agitation, for instance. But I think we should all have a very high index of suspicion for delirium in patients with dementia. And that's again where that collateral can come in handy as well, about what really is their baseline like. Is this noticeably different from how they normally are? So yeah, so it's a good question.
Good, thanks. And I see David's got a second question, so slightly different one. So I'm going to bring Janice's question. Janice mentions that she finds in her setting, workup is not completed and urine cultures are sent without good evidence of, and I'm going to hopefully pronounce this right, ASB, which I believe is asymptomatic bacteremia. So it's treated with antibiotics when not indicated. So again, the question is, finding in her setting, workup is not completed and urine cultures are sent without good evidence, and ASB is treated with antibiotics when not indicated. Any comments?
Janice, I think you raised two very important points. So, and I'm just going to put words into your mouth and hopefully you agree. But the first very important point is that, often if a patient is delirious, it may not be called delirium. It may just be sort of, that they recognize increasing behaviors or whatever. But there's a misbelief out there in many settings that all or most delirium is caused by urinary tract infections, and it's sort of the go-to sort of treatment. And as we know, and as you point out here, there are many other reasons. And so the problem is, if you don't call it delirium, then you're not going to think about the fact that delirium has many causes, and then you're not going to do, as you point out, a full workup, because there may or may not be urinary tract infection, and that may or may not be one of the 5 or 10 causes of delirium that are going on. And so you may not only be treating the wrong thing, but you might be missing opportunities to treat other things that are important. And then the second sort of point is that sometimes patients aren't even delirious, and they just have dementia, but we're treating them for UTIs that may just be asymptomatic bacteriuria, and so equally sort of problematic, just because we breed antibiotic resistance, and then when we do need antibiotics we don't have them there. So I think a very important point, and this is why as we become more aware of delirium and we advocate for its a proper management, that we need to be thinking about it bigger than what it is right now. So thanks for that question.
Thank you. And you've got a snappy comment from David on that. He says, pass opinion before you pass urine.
There you go.
That may help the people remember. We've got another couple of questions. Another question is there evidence of the prevalence of hypomagnesemia?
Magnesemia,
And thank you. We need the physicians to help with some of those. And hypophosphatemia in delirium. And this person finds the prevalence in seniors presenting with delirium. Any comments about those two conditions?
Well, I'll jump in here again. So several interesting things about that. Number one is that electrolyte disturbances can absolutely be a driver for delirium, and so important to look for it. In particular, in patients that have problems with potassium or have some evidence of some renal dysfunction, than magnesium. Less so with renal dysfunction, but certainly with other things, then phosphate can also be affected. But important, if there's one electrolyte abnormality, to be thinking about, are the extended electrolytes also playing a role, and to sort of do follow up and check those, because you'll never get the potassium sort of regulated if the magnesium is low. But I think the other really important point here is that sometimes patients with delirium aren't eating the same amount or anything just because of the delirious state, and if they go periods of time without eating, then you can get electrolyte abnormalities. But then if they do start to eat after a while, you can also get a little bit of a refeeding type syndrome, where all of a sudden the magnesium or the phosphate sort of goes low. And so if there's been extended delirium or an extended period of deconditioning where patients aren't eating, then you may find that there's subsequently other electrolyte abnormalities that come as a result of that treatment, which also need to be monitored for. In terms of prevalence of hypomagnesemia or hypophosphatemia in delirium, I don't know sort of how common it is, but it's certainly one of the things that you would want to look for. And I measure them in every patient that's delirious, just so that I make sure that I'm not missing anything. And then there's a follow-up there I see about delirium and length of stay. And so, certainly, patients that are delirious do stay in hospital longer. That is just a known fact. Like Katie, you said during the management part, we have to remember that some of our interventions in hospital may actually perpetuate or further cause more delirium. And so we have to be constantly on the lookout, not only for why did they come into hospital, but also what are we doing to patients in the hospital that might be causing that, and what can we do to reverse that, and what can we do to prevent sort of future episodes of delirium. So two very important observations.
Thank you. Got another interesting question about what's the positive predictive value of delirium in the medical history, and there's an acronym there. I'm not familiar with CARE4. So if you know what that means, go ahead and maybe offer some answer back to Jennifer there.
I think the CARE4 was maybe going back to the earlier question in terms of how do we recognize delirium sort of between from one admission to the other. I don't know what the actual positive predictive value is. You, Katie, know? I don't know the actual number, but it is high, but I don't know.
Yeah, I don't know what it is. I'm sure there are probably some studies out there that we could use to kind of calculate it, but it's a clear risk factor. That's all I can answer. So it's something that over time I've increasingly asked about in terms of history of delirium, especially to help with the differential diagnosis if you're not really sure. It's definitely a useful clinical question.
I do find, though, when you ask about the history, if you use the word delirium,
right,
sometimes people know what it is, sometimes they don't, but then you describe what delirium is and they go, oh, I was wondering, boy, have I ever seen that. And then you sort of get a whole history of often multiple episodes. And so it's enlightening. Like it can also form part of the education delirium standard, as well as sort of finding the history. So yeah,
that's a good example. And I'm just going to take an effort to translate from doctor to the other language in case there is a mixed audience joining us today. So when someone's referring to positive predictive value, they're referring to the fact that if we see delirium in the medical history, we're pretty sure we're going to see it again. Is that correct?
Yeah. So how? So if you're thinking about somebody has delirium, and then you find out that they've had delirium before, then the question is, does that make it more likely that they have delirium or less likely? And so this is how we sort of think about risk factors as we sort of find out about them. And so so obviously, if we're already thinking somebody has delirium and then we find out they have it before, then our certainty that they've got delirium increases quite significantly. And so that's the positive predictive value. It tells us that you know what, we're probably on the right line, because not only are we suspecting it, but we now have some further evidence that would increase the chance that that's what we're seeing and that's what's going on.
Thanks so much. I just know that we have a mixed audience and wanted to just make sure everyone's clear on the question there. We have time for a couple more questions. David's expressing his frustration around the diagnosis hypoactive delirium when there meets a dementia diagnosis. I think it's the intersection between the two. He notes that this hypoactive delirium seems to favor families that deny dementia. Any thoughts about his comments there?
So hypoactive delirium, maybe as a more like a preferable explanation for cognitive impairment, I guess, which I'm sure does happen. You know, people prefer to have a potentially reversible condition over dementia. Hypoactive delirium, though, it still has to meet full criteria for delirium. So, you know, they still have to have an acute change from baseline, right? And potentially a fluctuating course, and they have to have this change in alertness. And alertness, of course, can be hypervigilance or hypovigilance, which is where we could either see agitation or reduced, you know, engagement with the environment. So I think hypoactive delirium often is underdiagnosed because, you know, the patient's not causing problems. They're just kind of sitting there and not, you know, they're confused, but they're not agitated. So that's, yeah, I mean, that's my experience with hypoactive delirium. There used to also be a question of, should we treat it with like antipsychotic medications? Now we know definitely not. So we're using, you know, still behavioral interventions, but not typically medication treatment beyond treating the underlying cause. I don't know if Kevin had anything to add.
Yeah, I think that's a good summary. And I mean, certainly, you know, anytime we see delirium, you know, I'm always thinking about, you know, is there some cognitive impairment there? I don't think there necessarily needs to be cognitive impairment, but what I do find is that, you know, if there is some cognitive impairment or some neurologic disorder that's present, or some other sort of major illness, sort of chronic illness, then the amount of insult necessary in order for somebody to get delirious becomes less. And so we see it more often. You know, there are perfectly healthy 20-year-olds in the ICU who get delirious because they're really, really sick. But then there's people who have minor infections, but they have cognitive impairment, who also are delirious. And so, you know, in my mind, I'm always thinking, you know, does somebody have some cognitive impairment? Doesn't mean that they do, or doesn't mean that they don't. It's just something that I would be going through in my mind. And so I think an important part of that education is around, delirium is present right now. We're going to try to identify all the risk factors, but some of them are things that might have pre-existing and they might be ongoing, including dementia. So being delirious doesn't mean that you don't have dementia. And also, like Katie mentioned before, if somebody is delirious, you know, we try to treat the underlying cause as quickly as possible. We try to prevent, you know, it from getting worse as much as possible, but often people don't come back to their previous baseline. And so they may be left with some cognitive impairment after the incident of delirium. And there's been some studies done with neuroimaging, functional neuroimaging of patients with delirium that actually shows that there's some major pathways in the brain that break down in patients that are delirious and don't always completely come back to normal. And so it's important in the education to talk about all of those aspects as well.
Thank you. And you're getting some support for those comments in the chat as well. Just before we close out, we were intentional today about asking a geriatric psychiatrist and a geriatrician to talk about the management and all these aspects of delirium. I just wondered if the two of you have any comments about those perspectives. It sounded like your presentation flowed very well, lots of common themes, but did your different perspectives weigh in at all? Any thoughts?
I mean, for myself, I always appreciate having input from geriatric medicine colleagues. I think the lens, from geriatric medicine is very comprehensive in terms of especially the medical workup. to identify underlying causes of delirium. And I mean, I certainly get involved in that, especially in, you know, settings where we maybe don't have as much access to internal medicine. But having the input is invaluable from geriatric medicine. And then I kind of see my role as being more so like screening or diagnosis of delirium, as well as in terms of when pharmacological management is required for agitation. I think that's where, you know, I can provide some input from a psychiatry perspective.
Thank you. And in the last 30 seconds, Kevin?
Yeah, I think there's a huge overlap between what we see and what we're able to treat. And we definitely see that even when we're making a presentation, we approach things very similarly. Having said that, I have very much appreciated my geriatric psychiatry colleagues when I'm not sure about a diagnosis of delirium, and it's sometimes nice to have them weigh in. Likewise, I've been asked by some of my colleagues to weigh in terms of the medical management or my opinion. And so I think there are many opportunities to work together, and I love whenever we can be collaborative and you know, put different perspectives into helping the same patient.
Well, on that note, thank you very much. Just a reminder that there's the coaching series. If you want to continue the conversation, the information is still up on the screen. Susanna has posted the Delirium Standard link in the chat for you. And thank you for the kind comments. And thank you both for your excellent presentation and your wonderful responses to the questions. Bye, everyone.
Thank you.
Bye, thanks for coming.
Having us.